Hello, welcome to On Becoming a Healer. On each episode of this podcast, we talk about attributes necessary to becoming an effective healer. Challenges like engagement with people we wish to help, boundary clarity, judgmentalism, making decisions in the context of a patient's life. I'm Saul Wiener, and with me today is Dr. Stefan Kirtez. Hi, Stefan.
Hi, Saul.
So, for those of you who have listened to previous episodes, usually it's Stefan who does the introduction, but today I'm doing it because Stefan is going to function as my guest, even though we are typically co-hosts. I'd like to interview Stefan today because of the topic, which, as you know, is about opioid prescribing. This has been an area of enormous interest for Stefan. Those of you who are familiar with Stefan's research and his public advocacy can probably guess that we are not going to just rehash the usual narratives that you so often hear. So, Stefan, let's get started. How would you like to begin?
I think it's probably worth just acknowledging some of the factual history before we move into describing failures in clinical care that have been of great concern to me. So let's step back and recognize that we are now operating at a time when prescribing of opioids has fallen precipitously from 2012 to 2021. Those prescriptions rose from 1991 or so until 2012. And now, on a per capita basis, they are back to the levels of 1993 today. Overdoses involving opioids of all kinds were initially rising in parallel with those prescriptions. And then when those prescriptions began to come down, deaths that involved drug poisoning continued to rise, and it became clear that the poisoning deaths included heroin and later illicit fentanyl and sometimes still prescription opioids, even if they're not prescribed to the person who died. Sometimes they were. In that story, what drew my concern starting around 2016 was the recognition that a lot of patients were being taken off these medicines, and I was worried about them. Depending which estimate you look at, there probably were 8 to 10 million people on prescribed opioids in 2013 or so, and that number has fallen. And a series of studies have come out showing that when prescription opioids are stopped, very often that's done rapidly, it's done abruptly, it's done without consent, and increasingly physicians in primary care are simply unwilling to receive patients who've been on these medicines. So we have to get into the question of what happened here. How did they go up? How did they come down? And that's what I'd like to talk about.
So one of the things that I think is really interesting that kind of led to our deciding to do this podcast episode is when you and I were discussing this whole problem of what's happened with essentially forced tapers and the consequences for so many patients, you had the insight that there was a certain odd parallel between the trouble that got us into the opioid epidemic and the trouble we're having getting out of it when it comes to the role of the physician. We talked about the fact that there were clearly lapses in the way in which physicians were prescribing these medications, which I think are well known at this point. And on the other hand, what we've been seeing since there's been so much emphasis on deprescribing and getting people off opioids is that physicians are having trouble getting it right yet again. While they were so sort of overly exuberant in prescribing these medications, now they're sort of overly exuberant in deprescribing them. And it raises fundamental questions about how we as physicians are functioning in a larger society. You know, during the opioid epidemic in the early years, what we saw was this enormous pressure from pharmaceutical companies and marketing that kind of convinced physicians that you really couldn't go wrong as long as the patient had a need for a pain medication. And that led to massive prescribing. And then now there's enormous pressure coming from regulators, government, society, that physicians should, stay the hell away from these medications. And now we're seeing doctors who just refuse to take patients who are on opioids or who just yank them off them. And that's having devastating consequences as well. So it raises concerns about physicians' capacity to function wisely and judiciously in a larger environment. And, the question is, why are we so vulnerable to these larger forces? I sort of thought that the whole point of going to medical school and spending so many years training and having a college education was that it would give you a certain amount of wisdom, independent judgment. And yet what we're seeing is physicians have had trouble with that on both sides of this pandemic. So I know there are some cases that you and I have talked about that are sort of illustrative of these problems. In fact, I know you have many, many cases, but we picked two just for today's session. And let's turn to those, because I think it's always helpful to talk about these challenges in the context of real care. So these are real patients, and of course, I know you've changed identifiers and you've changed things up a little bit so they're not identifiable. Yeah. So why don't you start with the case that got us that sort of exemplifies the situation that got us into this?
Yeah, I'm gonna offer two cases, one sort of on the way up and one on the way down. I do want to stipulate that I use terms different when we describe this challenge with opioids. I have shied away from the use of the word epidemic in part because it reflects a view that the chemical itself is an agent of disease. And I don't know that I've settled that that's my view, actually. And so I tend to say things like opioid crisis or addiction crisis or poisoning crisis, different terms at different times. But sometimes I won't say epidemic out of the concern that we give that chemical category too much power.
And I just want to comment on how helpful I think that is. We don't generally refer to epidemics by the name of a drug, and so it's a good point that it's kind of odd that we would do that now, and it raises real questions about the odd way in which we're blaming a drug rather than a system. I mean, opioids have been around for thousands of years, and they can play an incredibly important role in giving people comfort and protection from pain and suffering. And so, yes, I think you make a great point that we have to even wonder how we ended up naming an epidemic after the name of a drug.
So, yeah, thanks a lot, Saul. Let's talk about these cases. So let's cast our mind back, and I'm going to remember maybe 6, 7, maybe 8 years ago, I inherited a patient who came from a different practice. And it was an individual who had very severe musculoskeletal surgery history, had been on prescribed opioids for a long time. The doses that this patient was on when I received them, depending whether you trust the computations or not, were somewhere north of the equivalent of 300 milligrams of morphine a day, maybe a bit higher than that. And when I received the patient, I initially just stabilized, kind of continued the medicine, began to get to know a little bit about his life, which was not an easy life. There weren't strong relationships in his life other than an ex-spouse. And I was feeling a little bit of pressure to try to taper patients at long doses. And I actually reduced maybe 5%, 10% with his, I would say, grudging agreement. I'm not 100. I don't believe that was, in retrospect, fully authentic, but it was a grudging acknowledgement that we should try. And after the 5% or so, I stopped because he said he was miserable. And I said, okay, I'm done with this. I don't have evidence that reduction is worth doing. But the more important thing is that I began to ask more questions at that point. And it probably was because of you, Saul. I think there was conversations we were having about the importance of asking why is the story this way? Why is this person living this life? What's going on? And I asked, how did it happen? Why did it happen that you wound up on these high doses? And of course, they described a prior doctor, and they described the serious orthopedic problems and the surgeries that had failed. And then I asked about the timing of when the doses were most increased. And it wasn't around the time of surgery or a failed surgery. It was around the time of a family tragedy. Specifically, his second daughter died. An adult. And the first one had already died. So he lost both his legacies. And at the time of that second death, his pain to him felt much worse. And he told the doctor. And in that moment, I began to think of the rise in his dose as kind of a reaction to grief intersecting with pain. What do you think of that?
Yeah, I think that this is a profoundly important point. And I think what I like about this particular case, for the sake of today's discussion, is I know that this was actually a well-regarded, competent, thoughtful, caring physician from things that you've told me. And we intentionally didn't pick a case that would come from some sort of ill-intended, lazy, inconsiderate individual. No, this was not the situation here. And what I think the case exemplifies is how physicians often failed to really get to the context. And to get to the context really comes through, and again, we've talked about these themes in many other episodes of On Becoming a Healer, engagement. And engagement occurs when you form a genuine connection with a patient and a partnership. And that will intrinsically lead you to start asking critical questions about that patient, about their life, the same things that you might ask a friend who or someone you cared about who is coming to you in pain. Rather than simply saying, okay, well, it sounds like we need to go up on this dose, you would probably say something like, wow, I'm so sorry that you're suffering, that your pain's gotten worse. Can you tell me a little bit more about what's going on? And that in the same way that you would, I think, instinctively talk to somebody you cared about, hopefully you would also care about your patients. But I think that so often what happens is that when we're with our patients, we get into this kind of efficient task completer mode. And we start thinking more in terms of, okay, well, pain is worse, time to add more medication or whatever. We're looking for that kind of quick intervention, something we probably wouldn't do in a friendship. And so that's why this sort of model of engagement, of seeing the patient as sort of being on a level playing field and asking them sort of obvious questions is what seems not to have happened in this case. And that, of course, is, I think, the point that I believe you were getting at. Is that what you had in mind?
It is the point I had in mind, but now I want to play a couple of counterfactual questions. I want to play the skeptic on my own story. So I could imagine someone saying, okay, fancy Dr. Kertész, you think that if you could identify profound grief at the loss of a child, that you would have a better solution than prescribing opioids? What exactly equips you after medical school, maybe as a young doctor, to counsel a parent about the loss, one of the most severe losses they could ever suffer in life? Why do we think we can help with that?
And I think my thought about that is that you would respond not as a doctor, but as a person. You would respond and say what you're thinking and what you're feeling, which is, I'm so sorry. That's horrible. And one of the things about physicians is they think they have to have a fix and a solution. And some things in life are just too difficult and too painful, such as the loss of a child. But certainly adding opioids is not the solution. And the solution begins with a human response.
So, and I have done this in clinical appointments. I've sometimes said, look, I think a lot's going on here. I think we need to think about, because I think we need to think about your pain as being driven by multiple things at once. I have to tell you that many patients have had this experience where a doctor references the emotional state that is intersecting with their pain, and they hear something which maybe we're saying, which is, I think it's all in your head. And that apparently is very dismissive in tone. And it may not be that those words cross directly from the lips of the clinician, but they are heard. So now I'm thinking, well, how do you show that you're aware of this, that you're present, without somehow, what is the delegitimizing element that I hear back from patients who are saying, they said it was all in my head. Damn it, I'm pissed.
I think that that angry response comes from a patient when the physician has exhibited some kind of patronizing quality in the way in which they're interacting. I think that when a physician reacts as a human and says, I'm so sorry, that is awful, I offer you my deepest condolences. Now, I don't think a patient's going to respond to that with, oh, you're telling me it's all in my head. I think a patient will respond to that with appreciation and gratitude for being recognized for the suffering they're experiencing. Now, the patient may come back and say, Doc, but my pain is still terrible. It's gotten so much worse since my daughter died. Can you go up on my medications? And that's the point where the physician can become more specific and can say, I'm very concerned about that approach because this type of medication is not intended for the kind of pain that you're describing right now, however you're feeling it, for the pain of grief, which is exacerbating your physical pain. And in fact, if we go up on medication in that context, there's a high risk that it'll cause you grievous harm. And so let's talk a little bit more about how we can approach this. And I do have some ideas. And that would be the beginning of a conversation that would start to look at what we now call multimodal approaches to pain management.
And I don't usually present myself as a pain specialist or pain expert, but I do use words like that. I don't actually rule out changing a prescription, but I would only do it as part of a very coherent and carefully negotiated, agreed upon plan that it seems responsive to the situation. But I usually wouldn't want to treat grief with opioids, to be quite honest.
Let's
Wait, I have to play skeptic one more time.
Sure.
I mean, we've situated this story of a good doctor raising doses as a kind of failure in a relationship. And someone out there, maybe a reporter, maybe a journalist, maybe a doctor will say, look, no. This isn't about a relationship. This is about criminal or near criminal corporations that flooded the curriculum or flooded the airwaves with messages encouraging a certain kind of behavior. And we don't need to talk about the relationship here. We need to talk about commercial promotion and indoctrination through the medical education and other establishments. So maybe that's the story we should be talking about. Maybe we're off base here to be situating this as a relationship failure. What do you think to that?
I think the answer is we need to be talking about both. And we've been talking a lot about the pharmaceutical story, but not enough about the doctor-patient relationship.
Huh.
And that's, of course, why we're having this episode today. I think that physicians can always insulate themselves to some degree from these external pressures if they always engage and they always think that they begin the clinical reasoning process in partnership with a doctor-patient relationship. In other words, I think that if physicians always treat their patients as partners, obviously assessing the differences in levels of education and expertise and taking that into account during the conversation, but if they always have a sense of respect with a sense of shared humanity, the idea that fundamentally this is a person who I'm going to work with in partnership with, that becomes the foundation for wise clinical decision-making that is insulated from the pressures that are coming from a variety of external forces.
Obviously, I agree with you. I mean, when I was playing a little bit of straw man there, and it's because I feel that the relationships that we establish with patients are essentially erased in the public discourse about this opioid challenge, that almost all reporting is about what did industry do, what did states do, and that doctors are described particularly in the run-up of prescribing, they're described as passive vehicles who essentially have no agency. They're literally dolts. I mean, that's how they're described. And maybe we somehow encourage that within our own profession, but there is no room even to describe how actual interactions with patients could occur or should occur or did occur, other than to say we're kind of passive recipients of messaging, which is a vision that I found bizarre. And it certainly has never been my vision for how to do healthcare.
Yeah, I mean, imagine two scenarios. In the first scenario, the physician is just listening to the messages that are coming from outside, which is, oh, okay, opioids are great treatments for pain. I just need to make sure they're in pain, and then I can go up on the opioids. Or opioids are terrible. They are killing people. I just need to get them off opioids. And that's listening to external messages. And if that is all that's driving the physician's decision-making, that physician is going to be whipped around by all of these external factors. Now, contrast that with a physician who's always beginning by saying, I need to get to understand why this person is suffering, how they're suffering. I'm going to ask them. I want to understand a little better what's going on. And then together, we're going to figure out how to proceed. In that latter scenario, that's what I mean by there's a lot of insulation there because it's inward looking. It's looking into the relationship, into the life of that patient, rather than thinking about, what am I being told? And of course, what you're being told is useful as well, but it's where you begin. And it's always grounding decision-making in the context of caring about and trying to figure out what's going on with your patient as a person.
And that to me seems like an opening to the second case, which is about the decline in prescribing and the way we did it, which I've termed incautious stoppage. So just as a matter of factual background, there are at least 3 papers that just show that there was a lot of stoppage of long-term prescribed opioids after 2012. One of them showed a 49% relative increase in percentage of long-term opioid patients who were stopped, and that the majority of those were stopped abruptly. And I saw this in the health systems I worked in, that messages sort of came out and people felt under pressure to stop. Sometimes even stopping in a single day. But I want to talk about a case that kind of dramatized this to me as I was beginning to observe in 2016, 17, 18. I was working in the hospital. I was working in the hospital as the inpatient ward doctor. We admitted a woman who had been on long-term prescribed opioids, but crucially was in kidney failure. This kidney failure happened in a unique context because this woman had received a transplanted kidney many years before, and the transplant was failing. And we dug in a little bit to the history, and I should go ahead and acknowledge for the nephrologists out there that when kidneys that are transplanted fail, there's a complex set of pathologies that are often going on over a decade. But in her case, she had lost the ability to organize her own life and the ability to organize her own medications. And she wasn't demented, and she hadn't lost a key social support, but in fact had been on high-dose opioids for many years and more or less functional, and then been taken down not 10% or 20% or 30% or 50%, but about 90%. And somewhere between the dose reduction from 70% to 90%, she basically lost all energy. She lost all ability to kind of get up in the morning and get things happening in her life, like taking those medicines that you normally have to take to keep your transplanted kidney from being rejected. And as things played out, what we saw was that there were very, very low levels of that drug, and that the kidney had some chronic changes, but also had acute rejection because, in fact, they had just sort of fallen apart. I'm going to stop there and just say, let's talk about the medical understanding of that phenomenon first. What's going on when prescription opioids are reduced? Is that fair, Saul?
Yeah, absolutely. And I think what you're getting at here is the disruption of an equilibrium in a person's life.
Yes.
And we see patients who have been on a stable, potentially high dose, but a stable dose of an opioid for a long time, and they're functioning well. And I think function is really important here. By function, I mean that their life is going well. They're able to work. They're able to meet their family needs. They're not asking for a higher dose. They're stable. Now, they may be on a high dose, but they're stable. And I think that the concept I find crucial here is that the decision to forcibly taper them, whatever you want to call that, or to taper them quickly without their full support, is a destabilizing event. And if that person is carrying out activities on a day-to-day basis that are really literally critical to staying alive and to staying healthy, then a disruption to that equilibrium can have devastating consequences. And I think that's what you're beginning to talk about here.
Yeah, exactly. Because the original pain issues that were in the chart, at least, were a variety of different kinds of musculoskeletal pains and arthritises. I think there could be some debate about whether prescribed opioids were the best treatment. I suspect they were not unreasonable, but that the dose escalations may have been not that well thought about. But somehow they wound up at a fairly high dose for roughly, 7 to 10 years. And when there's dependence, even if it doesn't qualify as an addiction diagnosis, you're going to rock the boat when you change things. And oddly enough, the individual did tolerate, as best I could tell, reductions for a while. I mean, they weren't done in very large steps. They were done in larger steps than would be recommended, but they weren't like all at once. But near the end of the process, and I talked very carefully about, well, what happened when you had this reduction? What happened when you had that reduction? And finally, she said, look, when they finally went from the last, 25% to 10% or so, well, then that's when I couldn't really get out of bed anymore. I couldn't function. And sometimes that's called a prolonged abstinence syndrome. I don't think it's crucial how we designate it. I think it's crucial to understand that this put the individual in renal failure. And, in the hospital, we increased those prescribed opioids that they were still going at a very low, just by a bit, but modestly. And I, sent a message to the doctor and I said, look, I realize that you were trying to improve matters for this patient, maybe make them safer through these reductions, but I think it went too far. We admitted this person for kidney failure, and it appears that that's related. And I think it'd be best to just declare victory at a 80% reduction, not a 90% reduction. And within a month after leaving the hospital, the doses that we had very gently increased were back down to 10% of the original again. There was no explanation in the chart. There was no account as to why that was being done. There was no hint that they had been even counseled about what was being done. And I, later had a chance to present this case at a scientific meeting, and I had to go back to the chart one more time in preparing the poster. And then I saw, they had another hospitalization for kidney failure about 5 months after the first one, and then yet one more 2 or 3 months later for death from kidney failure. And in fact, the individual was provided infinite fentanyl for the last 24 hours of her life. And I thought, so how well was the safety of this patient assured by making sure she didn't get opioids for 364 days or had a massively reduced dose for 364 days before her death, and then got infinite opioids for 24 hours before her death. What was the major public health function of that exercise? And it's an odd example, but let's ask if you have questions about that.
Yeah, so just to summarize, what you're describing here is a tragic situation where the disruption of an equilibrium through forced tapering of a patient led to a fatal downhill spiral. This is a patient who needed to be highly functional in order to take all of these anti-rejection drugs and to take care of herself, given that she'd had a transplant. And when her equilibrium was disrupted, she was no longer able to do that, and she ultimately lost her kidney, and then things spiraled downhill from there. And then there's this extraordinarily sad irony, which is that at the very end of her life, when she's finally on hospice, they're like, oh, we need to make you comfortable. We're going to give you as much of these opioids as you possibly need. And then she died as a result of that whole downhill spiral process that was triggered by the poor care she received. And, I think that both of these cases are almost two sides of the same coin. In both cases, there is a failure of the doctor-patient relationship. There's a failure of, I would almost say, of a human relationship, of a caring relationship. And in both cases, the doctor is reacting more to their own anxieties, to their own expectations of what they're supposed to do, and not to what the person in front of them. And I think that's what's so critical here. The other point I'd like to make is that function is such an important thing to think about with patients. So when you're caring for a patient, in this case, a patient who is on opioids, one of the most important things to think about is how are they doing? And is this somebody who is managing the things that they need to manage in their life? Now, it could be that they have a very challenging job. I'm thinking of a patient, as you know, I've talked a lot about my godfather, Simon, who's inspiration for this podcast and for so much else. Simon was a family physician, and I remember he had a patient who was actually an orthopedic surgeon. And this orthopedic surgeon had taken a lot of shrapnel when he was in the military and lived with chronic pain and basically took high-dose opioids for years and years. And as long as he took those high-dose opioids, he was able to perform at a very high level, was very successful as a surgeon, but depended on them. And I think we forget that there are a lot of people in that situation. Now, I think in the current era, we would probably be much more careful about putting somebody like that on opioids in the first place. But once you inherit that patient and they become your responsibility and you're responsible for their welfare, the question becomes, are they in an equilibrium state? In the case of the patient you're describing, she was. The equilibrium state for her was, is she taking her medicines and managing her very complex illness, which requires meticulous attention to anti-rejection medications, which she had been doing. And so she was living her life well. And I think it was more the anxiety of the physician about inheriting a patient on these high-dose medications that led to the disruption of the equilibrium, which brings us to another theme of our podcast, which is boundary clarity. The physician was reacting more to their own anxieties than to the welfare of the patient. And so I think in addition to there being a failure of engagement, there was also a failure of boundary clarity, which is something that we found in so many of the discussions you and I have had, factors into so much of the problems that we see in the doctor-patient relationship and in medical decision-making.
So now's the point where we have to introduce a question, and it's a question which we might actually disagree, Saul, and it's, does the narrative, the public narrative, cripple us from doing the right thing? Because I want to at least put forward the argument that the public narrative promoting those prescriptions in the first place was so powerful and built on that it overcame potentially doing the right thing. And unfortunately, I think the narrative of how we were done wrong by the pharmaceutical industry, the narrative I see in a show like Dope Sick, which basically portrays, there is actually no portrait of any patient on long-term opioids in that show who's functional. Every single story of an opioid is that it kills a patient or harms a patient across an entire season of a show. And that narrative basically says, these are always poison. Every doctor who prescribes them is bad. And then if you're a human being and you're a doctor, you say, well, I don't want to be seen as bad. So I guess I'll just cave here. I'll just cave in and allow that this messaging should overcome my judgment. So I want to argue to you that maybe this isn't just relationship failure, but that fundamentally there's overwhelming pressures that have been put on us. And we're whipsawed because those pressures are so high. That narrative is so powerful. Both the one that got us to prescribe so much, which was deceptive, and the one that is out there now, essentially, in which every prescription is almost a criminal act, or it is a criminal act. What do you say to that?
So the pessimistic hypothesis you're putting forward is that physicians are inevitably vulnerable to the pharmaceutical industry and to a variety of cultural pressures and are just not going to escape it. And if those pressures are going to push them to do bad stuff, they're going to do it. And there's not much we can do about that.
Yeah,
and,
we're sheep. That's the story I'm proposing for a second.
That we're sheep. Yeah, and then all you can do is take the pharmaceutical companies to court and make them pay and stop doing their thing so that physicians can start to no longer do bad stuff. And I think that that's obviously a very pessimistic view. Obviously, we don't know. This gets to deep issues of how people are shaped in their work. But I want to push back a litlittle bit. Let's take each of the two cases. So in the first case, the physician appears to have been inattentive to the grief that patient was experiencing that was behind their asking for more opioids. And it was never said, even during the crisis that led to the opiate epidemic, that if your patient is sad because their daughter died, just give them morphine. That was never part of the recommendation, even from the most cynical pharmaceutical companies. And so I think that clearly represents a physician's failure to engage, to show curiosity in understanding what their patient is coping with in their life. And had they done that, they wouldn't have said, oh, but I'm still supposed to go up on opioids because that's what you do when people lose their daughter. No, that was never part of the pressure, even at the height of the opioid epidemic during that upward swing.
Which I still call a crisis.
Oh, you still call crisis. Okay, we keep correcting me because I've been habituated to saying it the wrong way. Now, on the downslope, when we talk about the second episode, where there was a failure of shared decision-making, I think we can fall back to some basic principles that all medications have risks and benefits, and that when you are deciding whether to go up or down on a medication, it is supposed to be a process of shared decision-making, that you talk about the risks and the benefits with the patient, and then you make a decision together. Now, the physician should never do something that they believe and have evidence to believe is going to harm the patient. That would violate the Hippocratic Oath, and we're never asked to do that, even if a patient wants us to. But there isn't evidence that you should forcibly taper patients off of opioids when they're in an equilibrium state, when they're doing well. There just isn't evidence for that. And as you pointed out, there's quite a lot of evidence that it's a bad idea, that it can cause harm. So I think that the second case also illustrates how a physician who is doing what they're supposed to do, which is engaging with patients, taking a shared decision-making approach, would not have fallen into that same downward spiral that you described that is now causing some of the tragedies, the suicides, the breakdown in doctor-patient relationships that have become so common.
Just as a scientific point, there are a collection of observational research papers. More of them show suggestions of harm after reduction, sometimes fast, sometimes slow reduction, then show evidence of benefit when it's not a randomized trial. Now, when it's a randomized trial with consenting patients, those often look pretty good. But when the sort of observational work that looks backwards in large databases, there are a couple papers that don't show hints of harm. I want to acknowledge that the data is complicated, but there's just a pretty large number now that suggest the chance of destabilizing the patient seems to be higher than the chance of restabilizing the patient, taking all comers. I want to stipulate as well, I have reduced doses intentionally with a patient who did not agree when I felt that the patient was being obviously harmed by the meds they were on. So I want to embrace the concept that we're not obligated to adjust our decision to perpetuate something that we believe is causing active harm. The case I have in mind is of someone who was having very obvious toxic effects of multiple sedating and opioid medications all at once. It wasn't secretive. You didn't have to guess that the individual's falling asleep in front of me. So that is possible to do. Do we need a change from the healthcare system to restore the ability of our future clinicians to engage with their patients as fellow human beings and to listen for the actual story? Do we need a change in not just medical schools, but schools for nurse practitioners and schools for pharmacists? Or is this something where if we listen to a podcast, we're going to get better at it?
Well, I want to start by responding to that with a sort of optimistic perspective, which is that I've often heard physicians say that you just can't do the right thing anymore. That it's too dangerous. I'd love to keep you on your opioids, but I could lose my license. I can't do that. I'm going to have to stop it. And I don't think that's actually the environment in which we're in. And maybe I'm naive, but my approach has always been that you have a real conversation with the patient, and together you figure out what the best thing is to do. And if you feel like they are pushing for something that you feel is unsafe, ultimately you have the final word on that. But it has to be based on evidence. If you're not going to go with the patient's and your consensus recommendation because you feel there's a real harm to the patient, there has to be clearly clinical evidence of it. It can't just be, I could get in trouble for this. It really has to be your clinical judgment. And so I think the good news here is you can always do what you believe is the right thing as long as it begins with a serious effort to understand the patient's situation and to show them respect and to take what they are saying very seriously. And I think the way to take that approach is to document the rationale for your decision. So if you decide to keep the patient on the high dose opioids they're on because after a careful conversation, you have concluded that going down is just too risky, that they're functioning well, and that when you weigh the risks and the benefits, while there are risks to staying on a high dose, there are also risks to cutting forcibly, and that you have shared those risks and benefits with the patient, and that in your judgment, the status quo is the best option. If you put all that in a note and you put your reasoning there, all I can say is you're practicing good medicine. Could you get sued for it if there's a bad outcome? Absolutely. Could you lose in court? I don't know. I'm not an expert in legal matters, but my view is that you have made a very strong case for your clinical decision, and it's certainly the way I try to practice. And so I see that as a good news approach. I mean, again, maybe I'm naive, but I don't think that physicians are likely to get into trouble for doing the right thing and for documenting why they did the right thing and for taking a thoughtful approach. I think of course, anything can happen, but I think in the vast majority of cases, it won't. And I think that as physicians, when we take the oath to do the right thing. And I think we can do the right thing in the vast majority of cases. It will not come back to bite us if we take that kind of thoughtful approach.
I think this is a situation where informed consent, every medicine we prescribe, many of the interventions we do, at least incur a modicum of risk. I recognize that, and I didn't say this at the outset, but there's some efficacy, not wildly high, but some efficacy for opioids, for chronic pain. If somebody asks, I will get them reasonable links, but not high efficacy. But there is risk. I just feel that there's risks in lots of decisions that we make in healthcare, not just this one. And normally the way we approach complex decisions where the individual is suffering and where there is risk to the various possible pathways out of that is informed consent. It's I don't mean as a formality, like sign this document, but here's what I know. Did you understand what I just said? And what do you think about that? And here's the downside of trying out this approach. What do you think about that? And here's where I've landed in terms of what I think I can ethically do. And it's that conversation that should be the defense for good practice. It should allow us to avoid harming patients, I think. At least avoid harming them in ways that are reckless or crazy.
Yeah, and I think another piece to that, of course, is knowing your limitations as a physician. So if you're not an expert in pain management, you can be very open with the patient about that and say, this is a really tough situation, and I'd like us to get some help here. Yes. So I think it's going to be important for you to see the following expert. We're probably going to take a multidimensional approach to this, and we're going to go on this journey together. And I think that's got to be a part of the process as well.
Yeah, and even in this domain where I arguably have some expertise, I seek supervision, and I always have, and I still do. And I find if I think the case is tough, I'll come up with a plan, and I'll say, but you know what I'm going to be doing today? I'm going to have my colleague look this case over, and I'm going to discuss with her as well whether this is a reasonable approach. And my colleagues do that with me too. So I let people know where my limits are. And obviously, there are certain things I can't do. I can't stick needles in people's backs or whatever. That's not my skill set. But on tough decisions, we often get advice, and we often tell our patients we're going to do. We don't play God about it. We say, this is where I am.
Yeah, and so I think, Stefan, this is, I think, a really nice way to wrap up this discussion.
Yeah.
I'd like, of course, for you to have the last word, and you do actually have enormous expertise. You're being quite modest here. I know you're actually boarded in addiction medicine, and you've been doing research in this area for many, many years. But it's nice to hear that even somebody with your background looks for help sometimes, and that should be a message to all of us who don't have your background, that we often need help when dealing with these complex situations, but always fall back on the basic principles of being a healer, which is it's the relationship, it's the caring, it's the asking questions, it's figuring out how you can be helpful as a human being, and then drawing on your expertise as you can. So any further thoughts on that?
Yeah, so I'm going to treat this as a potentially healing moment for me. So anybody who knows me knows that at various times I've been angry, not exactly enraged, but angry about the policy environment and angry about the conversation that we're having around this topic. And sometimes I get very, very focused on the policy pressures, which I do think have been toxic to patients. At the same time, in talking to you, Saul, and I want to say thank you for this. It reminds me that at the core of this all, what we were trying to do, whether we're doctors, whether we're health professionals, but also in other parts of life, as humans, we're trying to establish real connections to people and to help them move forward. And that's a very worthwhile endeavor. It's a deep endeavor. And I think it allows us to transcend and step beyond even the rage, even some of the anger that I sometimes feel about this topic. And I'm really thankful to you, Saul, for walking with me through this conversation.
Well, I couldn't have said it better. So thank you, Stefan, as well. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have, and you haven't already subscribed, please consider doing so now. Take care, everyone.